Well, I think we can start. Hello again. Welcome to everyone. I'm Valentina from Eureka. And as you already know, we are here for the first REVAC Meet the Expert. So we are here with Dr. Carlo Lomonte from Università degli Studi di Bari. Want to share the Yes, you are. Carlo Lomonte, Università degli Studi di Bari. Jan Malik, General University Hospital in Prague. And Jose Ibeas, Park Tauli Hospital Universitari. So welcome all of you. And as already told to anyone, okay, please feel free to open your camera and to ask. We are here as a Meet the Expert. It is a discussion moment, so do not be shy. It's a very easy peasy moment to feel free to ask and to interrupt. And it's a moment for you for ask for something more. Of the professor, the topics of the teachers. So, can we start? You want to add something? Can we start? I will start. Okay, so we received some questions from the residents, and the first one is this one, then that I think could be directed to Dr. Malik, but as you know, all the teachers can add something. So the question is, taking into account that sometimes not all AVF complications are symptomatic, or at least detected by simple monitoring, would you think a periodical surveillance, for example, with ultrasound of the AVF would be a good idea for early detection of potential complications? So I leave the floor to Dr. Malik and then to all of you teachers, of course. Please.
Well, my answer is yes, but to expand it somewhat, ultrasound is a very, very precise method. If you are educated and experienced enough, and you can both diagnose the stenosis in a very similar way to angiography, but also you can measure the flow volume, which is very important for assessing the clinical relevance of the stenosis. And my experience, but not only mine, but also in the literature from other countries, is that many patients that have some severe stenosis were not diagnosed as a dialysis unit, but they were sent for such a regular ultrasound examination, and the stenosis was detected there. We also did a study that confirmed this approach. The problem is that the current guidelines do not support the ultrasound surveillance, which is not a good idea in my eyes, because ultrasound is something we or at least you all will use in your departments, and as you use stethoscopes, and nobody is telling you do not use stethoscope, but this is the same way if someone would tell you do not use the ultrasound if you have it and you know it. So this is my point of view, and I am ready for your questions or comments.
Mm-hmm. Okay, so I don't know if Dr. Lomonte, Dr. Ibeas wants to add something, or if there is the person that raised this question who wants to add something else, if the question and answer were good for him or her.
It may be important to know that Spanish guidelines and European surgery guidelines, vascular access guidelines recommend ultrasound for surveillance, arteriovenous access surveillance, but KDOQI and European best practice do not suggest, do not recommend vascular access native for surveillance. That is against the surveillance in arteriovenous graft.
This is an important comment, Carlo, because I think that for all of you as residents that you have to create your own criteria, you should recognize that you have the guidelines, you have beyond the guidelines, the last articles, you have the experience of your hospital, but you have to be able to create your own criteria, trying to understand the different articles that are going to be incorporated to the next guidelines probably. And this is important because the difference between the two guidelines, that some of them, the IRA and the DOCIT says no, and the Spanish or the ESBS, surgical one says yes, you should understand that when you read the letters, all the content of the guidelines, why is the reason that these guidelines justify this? Because perhaps you could be agreed with ones or with others. And this is important because the reason for what the guidelines says that you should advise or not is because for the surgical and for the Spanish guidelines, we think that there is enough evidence to advise the surveillance. For the European and the American one, they think that perhaps good, but there is not enough evidence. What's evidence? Well, you should realize that for say that we have enough good results with surveillance is because we get to increase the primary patency, the primary assisted patency, and the secondary patency. Primary patency is from the fistula creation until the first procedure to maintain the patency of the AVF. Primary assisted patency from the fistula creation, including all the PTAs or surgical procedures until thrombosis. And the secondary patency is even the fistula thrombosis until all the patency in the AVF until AVF loss. Mm-hmm. So there is a lot of evidence that say that with surveillance we can get primary patency and even primary assisted patency. But there is only one or two trials that says that the secondary patency can be got with surveillance. So the interpretation of the Spanish IBS says that, well, if we get primary assisted patency and we decrease the number of catheters, this is enough for our patients. And the DOCI guidelines, the European says, well, this is good, but we need more evidence and secondary patency and so on. Then, if you are enough confidence with that, perhaps if we don't have enough evidence, it's because there is not enough trials, then you should use surveillance. If you are waiting until to have the best evidence with 5 clinical trials in the next 10 years, you have to wait to check these trials, and then your patients are going to lose the opportunity to use surveillance. For the reason as important the guidelines comments are to interpret the guidelines. This is a crucial point.
Yeah, it's important to know that the surveillance should be based on the flow measurement. In your opinion, Jan or Jose, is the flow important more than stenosis itself? Well,
this is probably the summary of the content of this. The major part of all the content of our slides. The criteria based in imaging is history. The criteria based in hemodynamics, only the velocity inside the stenosis, is history. This is from the past. Now that we need is the flow, as you say, Carlo, because this is the clinical expression of the clinics. It's like the vascular surgeons in lower limb stenosis. Perhaps you have an important lower limb stenosis, but if the patient can walk, are you going to operate this patient? Or for instance, like Malik is cardiologist, are you going to treat a coronary artery with a stenosis of 40 or 50%? And are you going to treat a venous stenosis of 50 or 60%? Has no sense.
Yes.
The nephrologists, you are clinicians. You take decisions depending on the clinical of the patients. When do you advise to patients to do dialysis in chronic kidney disease? Depending on filtration rate or depending on the clinics of the filtration rate? This is important, the comment of Carlo.
It's important for the residents, yes.
Any comment of this, of all of you?
Do you agree?
Thank you very much. That was my question. Thank you for your explanations.
Very good question.
A pleasure.
Thank you, Patricia. And we have also this question that is quite similar to the first one. So, what are the possibilities of using the bloodless field technique, and what are the benefits? So, it comes with the first one, and it was directed to Dr. Lomonte, but if you think you have to add something, please.
So the preventive ischemia is a technique with the block of the nerve in the is important because is associated with the best outcomes, especially for the complication. When we have a fistula complications, as ulceration or aneurysm or pseudoaneurysm, it's important to perform the the intervention with a preventive ischemia, because we are not hemorrhage, not complications, and we do perform the optimal intervention without any complication.
Perfect, thank you. I think we can move to the third question. For all the teachers, in theory, is it possible to create an EVF in lower limb? If the answer is affirmative, why is more common to create an EVG instead of this type of EVF? Who wants to answer? You can start, Carlo. You can start.
Yes,
and then,
yes. The lower limb EVF or EV graft are associated with heavy complication, with high risk of complications, many infections, or still lower arm ischemia and pain. I remember one patient with arteriovenous fistula in the lower limb. I remember that the patient have a high risk of infection repeatedly and ischemia. So I think that from surgical point of view, the intervention is more demanding, and we should have a team of vascular access before we place an arteriovenous fistula or an arteriovenous graft in the lower limb. The risk of ischemia or the infections is very high. In the vascular access or graft in lower limb, we have many patients with ischemia, and after two years, only if 20% of graft are patent. The patency is too low, and infection risk is too high. For these reasons, we do not prefer AVF or graft or a native arteriovenous fistula to lower limb. It's better, in my opinion, a catheter, a tunneled catheter, and I think is so. What's your opinion, Jan and Jose?
Well, we have some patients with lower limb fistulas or grafts, and I would say they had to be carefully selected because of the infection risk, but also so the patient should understand clearly the risk of infection and to take care of the hygiene measures and so on. these are patients who have abundant upper extremity veins, and even there is usually no possibility of upper extremity graft. But I know some of them in which or in whom the lower limb fistulas work for years. But the problem is that atherosclerosis, which is quite common, is much more common in lower extremities than in the upper extremities. So this is something which limits our attempts of the legs.
Jose.
I agree with your comments. Totally agree that we have to select the patient because the patency is lower. Although in some patients with surveillance, you can maintain an important patency in selected patients. I would like to add the possibility in think always when we have no possibility to make a graft in the upper arms, mainly in the context of occluded central veins. Before to go to the lower limb, we have to remember that we have the hero as another possibility. The hero graft is a graft that is connected to the artery in the arm, but we have no options in the vein because we have central occluded veins. We can join it to a long stent graft. This is like a catheter that goes directly to the atrium. Then for this, you have to open the occluded central veins well with some dilators or some dilators or some device that can open this trunk, like the surfacer that sure you will hear about this in these training courses, that allows you to go from the femoral veins to the central trunks, open it, and after introduce a guide wire from the up down, and in this way to connect this graft to the atrium via catheter. It's like half graft, half catheter going through the occluded veins, and in this context you can use the lower limb graft like a last option. Okay, really see the same level. You can make the option of a graft in the groin or a hero. The question of the graft in the groin is probably taking into account the limited patency in some of patients.
I agree. Yes, but in lower limb, should we prefer arteriovenous access or catheter? What is the message for the audience?
I think this is not an easy question because if we think in the routine of the catheter like a last option, I think that the inertia should be also always taken into account to try first probably the graft and after the catheter, but always thinking that these patients are special patients and you have to individualize the option and personalize. Because in the context that we're moving from the fistula first to the patient first, this should be considered because as sometimes you say you have catheter during a long period of 5 years without problems, in some patients could be the indications. But otherwise, the graft should be considered like last option because you have probably lower complications in a general way than the catheters, but we have to individualize.
Yeah.
Okay, super. So Georgia just raised a question, Georgia Andriana, who is and it's this one. If there is any data about planning an AVF access in patients suffering from polycystic kidney disease, should we prefer SAVF from PAVF? She has just now write the questions in the chat. So for everyone, please feel free to open your microphone if you want to ask something, or you can do like Georgia did and write it down in the chat. So who can answer to this question?
You, yeah?
Please.
First, what do you mean by PAVF and SAVF?
I think probably surgical AVF or percutaneous AVF, I imagine.
Yes, that's right.
Surgical PVF.
Oh, I see. Okay.
Surgical and percutaneous.
Oh, I see. Well, in my country, we are just beginning with the percutaneous AVF, so I don't have much experience. But otherwise, I would take care of the polycystic kidney disease patients as as of the other patients, so I don't see any significant difference. Although I know they are a little bit more prone to aneurysms.
But what's the point? The resident that makes this question, what's the aim of make this question in the context of the polycystic kidney disease? Because initially shouldn't be a difference this kind of disease for the patient. Do you have some aim with this question?
I think because the polycystic kidney disease patients have a low diameter arteriovenous fistula, arteries and veins. So I think it's not possible to create an endo-AVF in these patients because the criteria are many. The diameter of the perforating vein should be 2 millimeters. It is not easy to found the patient with polycystic disease with these parameters, with diameters. I think the polycystic kidney disease patient may have an arteriovenous fistula, a native arteriovenous fistula, or distal, maybe with a microscope like Pirozzi, or I think we do the arteriovenous fistula in polycystic kidney patients.
Yeah, but
problem.
No, that's true, Carlo. But in any case, as you are going to say the patient depending on the mapping, with mapping, in
of course, yes.
Sure, you have different probability depending on the chronic kidney disease, the theology of the patient. But as finally you are going to do the mapping of any patient in order to choose the decision, if you are going to do one thing or another, probably the origin of the kidney disease is independent. It's like diabetes, no? Or with mapping you can select the indication. In fact, probably you have two kinds of endo-AVF approach.
Yeah.
One is if with ultrasound from the perforating vein going through the perforating vein to the artery below, and the other is through, you will check this, guys, and the other is through the or ulnar or radial artery, and with from distal or proximal, and with a guide wire in the satellite vein. And when you are close to the elbow, close the magnetos and make the fulguration in order to create the AVF. But in any case, it depends on the previous mapping, no?
Yeah. But the access is through the ulnar vein or the radial vein. 2 millimeters. I think it's not possible to in polycystic kidney disease patients to have 2 millimeters of diameter for introduce the material for performing an endo-arteriovenous fistula.
Mm-hmm.
So of course the mapping is is important.
So I move to the next question. We are in the first 44 hours from the creation of AVF. Is useful to give a low dosage of heparin to reduce the risk of thrombosis? I think Ibeas and Lomonte can answer to this one.
This is a very good question, very intuitive question, very common question, but the question perhaps should be considered always, like in any field of medicine, considering the pros and cons. Then it's useful, probably yes, sure, it's useful, but the balance or risk benefit of this usefulness should be considered, taking into account also the possible complications. That's the point. Probably, and if we go for the evidence, there is some meta-analysis published in the recent years. In the some very famous meta-analysis, including all guidelines, 5 or 6 years ago, or 8 years ago. Another one 2 or 3 years ago says that in native AVF probably could be useful use some kind of anticoagulants like heparin or antiaggregants and so on. But the problem is the risk of bleeding. The patient in dialysis have higher risk of bleeding, higher than the normal population. In fact, you know that we will have to use the coumarin in a patient with problems of cardiac rhythm. In some patients, we rule out the possibility, or we don't think in putting coumarin into these patients by the high risk of bleeding in the general population of uremic patients. So today the guidelines doesn't advise to use in routine the use of heparin or the coumarin in this kind of patients. Sure, you have to individualize. And in the prosthetic AVFs or grafts, here is clear the no indication of use not only 2 hours before, 2 days before, but previous to surgery, 2 days before, or even later on during the next weeks. I don't know.
European best practice do not recommend the prescribe the heparin during the procedure. In my experience, a low dose of heparin, such as 2,500 units in bolus, only during the intervention or the procedure. But there is not evidence. The risk of hemorrhage or the bleeding is very high in a certain type of patients. So we should avoid the heparin in post-procedure.
Great, thank you. I repeat for everyone, if you have some question or suggestion or details to add, please feel free to open your microphone or, like Lemis, write it in the chat. Well, I share the next question and then we go to the Lemis one. The next question is, do you recommend monitoring by ultrasound AVS periodically? I don't know how to read it, I'm sorry. If so, how often? Or you only check them when they start giving problems? This is a question for the three of you. Who wants to start?
Please.
Well,
yes, your turn, Jan. Or
well, I have already supported the surveillance, but nevertheless, if we speak about the native fistulas, we should know that up to 50% of them do not mature after the surgical creation. So this is when the ultrasound might help as well. So if you perform ultrasound of the newly created fistula, even shortly after the surgery, you can diagnose any problems that prevent maturation of the fistula. And this could be some stenosis after phlebitis or something like that, which could be treated easily by the balloon or surgically. And you can have the diagnosis. So in other words, you could have the diagnosis earlier, but also it guides you to therapy. So I would start very early in fistulas within, say, 3 weeks after fistula creation. We do perform surveillance of the grafts, but also of some high-risk fistulas in patients who have abandoned all other veins or have repeated PTAs and so on. So these patients come for the examination regularly in our institution.
Mm-hmm. So do you suggest the active surveillance in the post-operative period to increase the fistula maturation?
I would, yes. Well, in fact, if we speak generally about the fistulas have less complications than the grafts. So they have better long-term lifespan. Nevertheless, the problem of the native fistulas is that many of them do not develop at all. And I believe, and I have seen repeatedly, that if we perform ultrasound within 2 or 3 weeks after the surgery, we can very early diagnose the problem and treat it either by the balloon or surgically, and to help the fistula to mature. So it is of course done also in other centers, and it is called PTA assisted maturation. This is the case of native fistulas.
Yes, in fact, it's a question of not only the evidence that we have previously commented, but it's a question of common sense. We have, on one hand, fantastic machines to clean the blood, dialysis machines. On the other hand, the patients that should be cleaned. And in the middle, the switch, the connection, the vascular access. We check the machine, we check the patient. And we're going to check the vascular access. How no sense to not check the vascular access? First point. The second point is, in what a regular condition we should check the vascular access. Do we check the machine every day? We check the patient every day. Then we have to check the vascular access in a regular way. Then a normal vascular access, a regular vascular access without problems, at least should be checked every 2 or 3 months. Okay, the physical examination every day by the nurses, and even the physician should be checked every month. The problem is that the nephrologist doesn't check the vascular access never. And the nurses should be checked the vascular access every dialysis session. Then, if you have an ultrasound, that you should do is to make the ultrasound every 2 or 3 months. It works. If not, because you have some problem every month, like chronic kidney disease, the regular control. But the other crucial point is that the future of this is that the maturation process, as Jan says, should be done, should be made in a mandatory way once you have created vascular access. But the question is that probably who should do the vascular access maturation surveillance should be the nurse that is close to the patient. In fact, in our center, the maturation is controlled by the nurses, because who is going to need the vascular access when the fistula operation is created. But you as nephrologist should take care the decision of what are we going to do with this vascular access when the nurse has some problem. Because the nurse wants to make the cannulation, the ultrasound guided cannulations, only to put the needle in the vein, that have no sense. Because you want to put the needle in the vein, before I have to rule out the presence of some kind of pathology of stenosis. Otherwise, I'm going to needle a vein, perhaps without flow. So if this nurse is going to control the maturation process in order to detect as soon as possible the problems to be detected, to be solved, as Jan says, then you as nephrologist should take care of the condition or the decision-taking process in order to choose what you have to do with the AVF. So the answer is sure, as common sense, you have to make surveillance. Second, the surveillance should be made in a regular basis. And 3, you have to have a protocol what to do patient when it fails. So if we have the machine controlled, you have the device controlled, how are you going to be controlling the vascular access? This is the problem of why there is some kind of guideline says no surveillance. I'm going to tell you something. Depending on the country or the continent, the reimbursement is an important problem in order to take decisions or guidelines. Because if you have something that is free, it's easy to do it. But you have to put the reimbursements in this balance, in the balance of to do something sometimes for aspirin or for the coumarin, the balance risk benefit of thrombosis and bleeding. But for the diagnosis process is the risk or the benefit and how money that I have to pay for this. In a lot of countries, the surveillance is made for us, the nephrologists, cost 0. But in other countries, it depends to go to some suite, you have to pay. For this reason, if we think from an ethical point of view, rule out the problem of the surveillance, it's clear you have to control the switch, the connection between the machine and the human being.
In this regard, I would say that the vascular access is not a Cinderella or an Achilles heel of nephrology, because the AV access is a keystone of an arch that sustain and maintain survival, adequacy of dialysis, that are the outcomes, centered patient outcomes. This is very important, the vascular access.
Thank you so much. Lemis, you have raised your hand. Do you want to add something? Feel free to do it, please.
Hello. Yeah, I
Hi.
wanted to continue, make a continuation to that one. Since it is recommended to follow the AVF graft with the ultrasound, what are the early signs we could look for that would tell us that the AVF is not going to maturate properly? Could it be the thickness or the diameter of the, what could it be?
Well, thank you so much for your question. I would say it's not so simple regarding the numbers because in my view, much more common is that there is a diffuse, for example, calcification of the feeding artery. Then sometimes the veins are dilated, but there is a stenosis after a couple of centimeters and so on. So we should take it in a complex, and I believe that the numbers are only in this aspect, in the mapping, are such a general orientation points, because I remember one very sick patient. It was a boy. He was about 10 years old, and his radial artery was 0.8 millimeters, but he had no possibility for further catheters and so on. And the vascular surgeon created a functioning fistula, which functioned for years. So this is about the skills, about the general feeling, and so on. And the best, nevertheless, I think that the ultrasound ideally should be performed by the surgeon himself or herself, because he or she would know what to expect when he or she is opening the skin.
Thank you, Dr. Malik.
Thank
So,
you.
Lemis, you had another question, but I don't know if this one, you write down this one, and I don't know if it's still valid. I would like to know why is it that the arterial diameter is more important to the AF success more than the vein diameter? Jose.
What's more important for your heart? The right cavities or the left cavities? What is more important for you, the right or the left? I think that probably as important as that of someone is the other one. Is in any case, the criteria to choose the minimum diameter of the artery and the vein in a fistula creation, the evidence says that for both for the artery and the vein are in 1.5 and 1.6 millimeters. For 1.5, 1.56 is the limit, or as Jan says, even lower. The evidence published says that 1.5, 1.6 for the artery and the vein. For this reason, the people advise at least 2 millimeters to make the fistula. But the bottleneck is that if you want fantastic vein but a bad artery or reversal, you're going to have a problem. So you have to have a minimum criteria of 2, but in the whole length of the artery and the whole length of the vein. So in the mapping, you have to check the minimum diameter in the distal third, in the median third, and the proximal third of the forearm, and the same all the branches. But the more important is the main branches in the vein. After you have bifurcation is the same, or some collaterals, but all in the artery rule out the presence of minimum diameter of 2 millimeters are in the vein, in the main branches of the outflow, at least of a couple of millimeters. No? Although you can individualize patients, mainly women, with arteries of 1.4, even 1.3, or veins of 1.5, and it works, but with the artery without problems of important calcifications. Although with calcifications, you can do without problems the anastomosis, but higher diameters, and in the vein, ruling out the presence of fibrotic walls in the vein, because you are not going to be a possibility that this vein delays. In fact, increase the size when you compress the vein or when the vein has blood. In other words, you should put also a tourniquet in the arm and measure the diameter of the vein with and without this tourniquet. There is not much evidence in this regard, but there's one article that says that the increase of 45% of the diameter after the tourniquet, it says that probably this vein is going to adapt the size after the dilation. But the important is when you compress the vein with the ultrasound, I will check this in the hands-on, you will realize that the vein should be disappearing the screen. If you still see the vein because the walls are enough thick, this means that you have fibrosis in these veins, and even the diameter have 2 millimeters or 2.2 millimeters. If the thickness of the wall is important, probably these veins are fibrotic and are going to have problems in the maturation process. Otherwise, in the artery, there is another maneuver that is hyperemia index, checking the resistivity. After make the fist and open the hand, you can see how the resistivity decreases in the distal artery. And this is not a mandatory process, but can give you an indirect approach of the desensibility of the distal vascular bed. Okay? So it's difficult to say only the diameter of the artery. You should take into account the diameter of all the arterial branches, the diameter of all the venous branches, and the hemodynamics of the artery and the vein.
Yeah, according to the recent guidelines, both diameter are important. The artery diameter should be 2 millimeters and the vein diameters 2.4 millimeters for graft. It's important to say that if we place an arteriovenous graft, the vein should be at least 2.4 millimeters diameter.
An important consideration is depending the center you rotate all over the world. That means not in the United States. You can check that some protocols say that minimum diameter is 3.5 in the veins, and for the reason you see a lot of grafts. Then you have to create your own criteria. You have the guidelines. You have here the people that have some experience, but also important is you have to create your own experience, because there is something beyond the evidence, that is the last articles, but also the clinical practice in a lot of centers that is not published, but it works. This is very important. But you're not going to be able to identify the success of these centers if you don't know the criteria to recognize the success.
Gold. Well, thank you so much. We have just a couple of minutes. Do you want to raise any more questions? If you want, you can open your microphone, or you can write it down in the chat. We have already passed 45 minutes of this very interesting Meet the Expert, and I want to thank you so much. Last chance, do you have any more questions? You are here speaking with Dr. Lomonte, Malik, and Ibeas. It's such a great opportunity. Okay, so
I have a question for the residents.
Please.
How was your hands-on training in
Maastricht?
Maastricht.
Yes, because last week we had the Maastricht hands-on training. Is here anyone that was there last week? I don't know.
I was there.
You, Patricia, how was?
It was really nice. We did a lot of practice and a lot of ultrasound, and was amazing. Actually, we learned a lot of things with Dr. Martin Snoix. I don't know if someone.
Yes, Oscar was also.
Hello.
Hi, Oscar.
Hello. Yes, I was with Patricia in the hands-on training on Maastricht. I share her experience. It was a very interesting experience for us. We learned, I think, a lot about vascular access. It was planned for us to learn everything from the basics to the more complex kind of stuff. We had the experience to use the ultrasound to see patients, to practice on each other some kind of mapping for fistulas. We also learned techniques about creating AVFs. So we did a lot of hands-on, which is I believe the most important part to doing this kind of training. So yes, it was a very, very nice experience.
Thank you.
So, and next week, I think, yes, no, in the, well, at 8 June, we will start in Barcelona, in Parc Taulí, and then Milano. So next month we have, and then in July, Bari. So in the next month we will have 3 ensign training. Yes, great. Dr. Ibeas is excited. Great. We need your feelings. So, well, thank you so much. Thank you, Carlo. Thank you, Jan. Thank you, Jose. And thank you to all the residents. As you know, the recording will be available starting from tomorrow in our website. And next month we will have another Meet the Expert, but we'll keep on in touch, and I will write you about it. So thank you so much, and have a nice night. Thank you.
Bye.
Bye. Thank you.
Thank you, Jan. Thank you, Jose. Thank you very much. Thank you, Valentina. Thank you, all of you.
Nice to see you.
Thank you. Bye-bye.
My pleasure.
Bye-bye.